Hi guys, it's Dr. Ron Miller here with cashbasedphysiotherapy.org, and we haven't done this in a while, but we're going to give you another complex case to go over, something that I see a lot in a cash-based clinic that you may also, and this video may help you out with your clinical decision making and your thought process of how to treat it. So the case is going to be a 35-year-old with a history of left sciatica, and he's status post a microdiscectomy, but he still has the sciatica symptoms. So the purpose of this video is I want to go over a clinical, differential diagnosis and what I'm thinking about when this person went into surgery with sciatica, came out with sciatica, and they treated what they thought was the herniated disc or the root cause of it, but he still has sciatica. So let's go over some, like a differential diagnosis of what I think is going on that may help you out, and we can add some comments in the discussion box below. So the first thing that I think about with a 35-year-old male, obviously he had an MRI, they found a herniated disc, and they just went in there and did surgery, came out, he still has his sciatica symptoms. Okay, things that make it worse. Sitting still makes it worse. It causes the sciatica to go to centralize. Prone press-ups and doing some McKenzie stuff does temporarily relieve it, but as soon as he goes back to sitting, it comes right back. And even there's something else besides discogenic symptoms going on here. He can do McKenzie stuff, he can stand up and walk around, and his symptoms go away, but he has no tolerance to exercise, and he has the inability to sit. Whenever he goes to work, whenever he sits down, sciatica comes back. If he works on his computer at home, sitting again, sciatica comes back. If he's sitting watching TV, sciatica comes back all the time. And we pretty much exhausted the standard McKenzie approach with doing prone press-ups. It's not lasting. So there's something else going on here. Yeah, prone press-ups and McKenzie, repeated extension, reaching full extension, getting the repeated motions in does help. But what else is going on here? Why he can't return to sitting? Okay, why he can't return to exercise? Okay, one thing that jumps off on the top of my head is we have to address this. This is a hot topic now. Everyone's going to. I think it plays an essential role in here, but having fear avoidance beliefs. I think he does have high fear avoidance beliefs. He's scared that his surgery didn't help him. He doesn't know why he has pain. He's scared to move. It's not the main thing, but I think that this has to be addressed. So one, he could have fear avoidance problems that is inhibiting him from going back into flexion, forward bending, and he does have this. This has to be addressed. I don't think this is the root cause, but I think it's adding in to the problem, okay? Some other thing that he could have is neural tension, or like a scar tissue after the surgery, okay? He could have had this pre and post surgery, and I believe that he does have some neural tension still present. I believe that this is one of the things that I'm going to treat, but he may have some scar tissue from the surgery site that's nicking the nerve root, and it's sensitive to flexion. So every time that he has some neural tension or goes into flexion or forward bending or sitting, it's pulling on it, and thus he gets some neural tension, or it's pinching on the scar tissue that's causing the referral of pain down the sciatic nerve path. Okay, I believe he has this still going on. Okay, so neural tension, and again, a lot of this stuff, you'll see this in these types of cases where they go in with sciatica, come out with sciatica, and it was just a neural tension problem, or they don't even get surgery, they have a history of low back pain, and for some reason now they're having some ridiculous symptoms. Always look at the neural tension component of this, okay? Whether it's scar tissue in this case or neural tension, not sure, but I think he has some neural tension stuff still present, okay? This is kind of inconclusive, but someone could have a facet compression that is in L5-S1 area causing a referred symptoms. Normally, facet referral doesn't go below the calf, but he has true sciatica that's going down into his calf still. But with this one, you would expect standing, walking, prone press-ups, extension, or compression would all increase his symptoms, and sitting would make it better, okay? This is a possibility. You know, he could be laterally pinching on that side. If he has, like, maybe if symptoms are going down the left leg, he could have a right pelvic shift with a left trunk shift that's compressing that also. He doesn't really present with a lateral shift, but the facet joint compression could also mimic sciatica type symptoms, but in this case I don't think that's occurring, because he would say more prone press-ups cause it, standing walking causes pain, sitting makes it better, okay? So I don't think it's a facet joint compression problem, but it is in my differential diagnosis of what I'm thinking about. Something is still causing a sciatica, and it's up for us to solve this, okay? So another thing that I think that could be going on, he could have SI joint pathology that is directly compressing at L5-S1, okay? So this is thinking outside the box a little bit. You know, with this, I think he has a little bit of this going on also, because his left leg always appears longer in supine. You can do some leg length SI joint pathology stuff, meaning in this case the left SI joint is more in an anterior rotated innominate, and with that he was lacking left hip extension, and the left leg is going to appear longer, so he's rotated. We all know that research shows it doesn't truly move, but this is just the pattern of treatment that you're identifying that's pinching at L5-S1 in sitting, thus causing his pseudo sciatica, okay? So that's another option that could be causing this, okay? I should be able to restore normal hip extension, correct this innominate, and then his symptoms go away. This is, this helps. Every time he comes in with increased symptoms, he's always lacking left hip extension, things got tight. This is more so the route where you're gonna do the iliopsoas release. You maybe do an HVLAT to the innominate into posterior rotation. You'll be doing some instrument-assisted soft tissue mobilization to the left rec fem, anterior hip stuff, restore normal hip extension, so you get him into a posterior rotation and you're gonna activate the glutes. This works for him, but it just doesn't last. So again, I think this is a piece of the puzzle with this, because every time he comes in with increased symptoms, he's lacking hip extension and his leg longer again. Okay, so I think that's a possibility too that you have to look at. Maybe it's not true L5-S1 problems, but maybe he has a SI joint problem that could be causing this, okay? Another possibility that I'm thinking about is there a hip pathology? What do I mean by this? Okay, so yes, he does report sometimes with true lower back pain, but we know that labral tears can refer to the back, and he could have some true hip pathology that's mimicking his sciatica. Two things that come to mind are going to be maybe piriformis syndrome versus hamstring syndrome. Okay, and we have to rule this out. Yeah, it doesn't make sense why he's getting his back pain from this. His back pain doesn't fit a problem, it's just a diffuse ache across his back. But does he have piriformis syndrome that's pinching the sciatic nerve, causing a referral of sciatica in sitting? Or does he have hamstring syndrome? Okay, a lot of cases, this is more common in runners with a new training style or doing hills, but hamstring syndrome, that proximal attachment of the hamstring can thicken over time and nick the sciatic nerve, where the sciatic nerve passes right by that area, thus causing a pseudo sciatica type symptom. Okay, so these are things that I'm currently ruling out. I don't think he has hamstring syndrome, but something's going on here, because I had an interesting finding. When I did a deep kind of hip flexion, external rotation, posterior inferior glide to the hip to help increase some hip extension, I do reproduce some of his sciatic symptoms when he's supine. So, there is some stuff going on at the hip that I have to dig deeper in. So this is an interesting case. I don't think it's a facet joint problem, but I do think he has some of this other stuff going on. The good thing is that I'm educating him about, I'm getting this going down. The neural tension, I'm going to start now and add this into it. And this is kind of secondary stuff, I think, going on. But I may start really addressing this one, number one, with the neural tension stuff. So, and I left 6 and 7 blank here. So I wanted to present this question to the group and to the followers, and let's problem solve. Am I missing anything? Do I have to go into pelvic floor, obturator internus? Is this a possibility? Do you guys see that, who are the pelvic health experts, pelvic floor experts? Do you see obturator internus as a problem here? Am I missing some stuff? So let's brainstorm together, on a case like this. Middle-aged male, young male, history of left sciatica. Goes in, gets a herniated disc removed, could have been just a bulging disc. Walks out of surgery with the same sciatica symptoms. Let's problem solve together, and am I missing anything? Can I fill in these blanks here? But this is just my thought process of when I did the eval. This is what I was thinking about during the eval, and as I start treatment with him of, why is he still having sciatica after having a microdiscectomy? So obviously fear avoidance, neural tension or some scar tissue. He could have facet joint compression, which I ruled out. He could have some SI joint pathology that's leading to an increase in L5-S1 compression, causing the referred sciatica. And he could have some hip pathology, like a piriformis or a hamstring syndrome. So this is just my differential diagnosis during the eval. Let's get some discussion started and see if we can add some more things to this list that you guys have experienced. So if you ever run into a case of this, you'll know exactly what to think about and to rule out, and it will help you with your clinical decision making and problem solving on what's the best way to treat this. Yes, we've seen this before. Let's solve the root cause and be able to provide better outcomes to our patients. So I hope this helps. Please, if you have any recommendations or ideas or new concepts or new differential diagnosis ideas, put them in the comment box below, and let's create a good discussion off of this case. So thanks for tuning in, and we'll talk soon.